This is Dr. Hessel recording the podcast on arterial blood pressure monitoring for Tuesday, September 24th, 2019. This is an outline of my presentation. This PowerPoint presentation, also an expanded version of this PowerPoint, will be posted on Canvas. The reading assignments are been given to you. I highly recommend this section in Miller's Anesthesia 8th edition. There are many reasons for monitoring arterial blood pressure as summarized on this slide, not the least of which is that it's required by the ASA. This, as you recall, the ASA Basic Monitoring Standards requires that every patient receiving anesthesia shall have a blood pressure determined at least every 5 minutes. One important question is, where is the reference location for arterial pressure? Because of the effects of gravity on pressure within columns of fluid, including inside the arterial and venous tree, or saline inside a monitoring system, pressure varies with vertical elevation. When the patient is level and the transducer is the same level of the patient, it makes no difference. However, when the patient is not level, or when the transducer is a different vertical location than the patient, then discrepancies occur. The arterial pressure varies in various parts of the body due to gravity. It varies about 0.7 of a millimeter for every centimeter height. Therefore, if measure pressure in the arm or the leg with non-invasive device, you must correct the pressure reading by this amount to determine the pressure in the brain. If you use an arterial line, the transducer should be placed at the level of the head. This is an illustration when the patient is elevated about 30 degrees. It turns out that the head is about 30 centimeters above the heart, which is equivalent to about 20 millimeter pressure difference. The same gravity effects is true in fluid-filled transducer systems. When the transducer is below the body, it will read false high readings and vice versa. Cerebral perfusion pressure is the difference between the mean arterial pressure in the head minus the intracerebral pressure. Therefore, both transducers should be at the same level, and this level should be at the head. If the head is elevated above the heart level, the arterial pressure at the head will be lower than at the heart level. If you don't adjust, you will get a false high calculated cerebral perfusion pressure. This is illustrated in this figure. Note that if you calculate cerebral perfusion pressure as the arterial pressure minus ICP, if you measure the pressure at the heart level, the cerebral perfusion pressure will be 60. But if you measure the pressure at the head level, the cerebral perfusion pressure will only be 40. This is also illustrated from this figure from a paper by Dr. Drummond. While most authorities agree with this concept, not all do agree, and this will be further discussed in the expanded version of the PowerPoint presented on Canvas. Arterial pressure is classically measured non-invasively. This was first described by Riva Roki in 1996. Then Korotkov described Korotkov sounds and use of auscultation. The use of oscillometry was first described early in the last century, but it became common in the mid-1980s. Finally, there is a new method which we'll briefly mention later on, using a finger cuff. The most common method nowadays used in the operating room and also in other environments is called oscillometry. This device measures the pressure in the cuff at the same time the cuff is inflated. A microprocessor analyzes the oscillation in the cuff produced by the pulsating artery. Pressure is applied to the cuff, and at the same time the pressure in the cuff is monitored by the processor. This displays when pressure is applied to the cuff, this is the pressure, and then gradually lowered, this is the pressure applied to the cuff. Conversely, at the same time, it measures oscillation in the cuff. Note that when the pressure in the arm exceeds the systolic pressure, there's no oscillation. When the pressure starts to fall below systolic pressure, oscillations appear. They gradually accelerate and then gradually decelerate. It turns out that the mean arterial pressure can be estimated by the point of maximal oscillation. This is the most accurate measurement obtained by oscillometry. The systolic pressure and diastolic pressure are estimated based on various proprietary algorithms that determine when oscillations start to increase, which is defined as systolic pressure, and when they stop decreasing, which is defined as diastolic pressure. This is illustrated on this diagram. The most accurate arterial pressure measured by oscillometry is the mean pressure, the systolic is the next, and the diastolic is the least accurate. For accurate non-invasive blood pressure measurement, the cuff size should be appropriate. The bladder should be placed over the artery. It should be a well-fitting cuff, and you should choose the arm with the highest pressure. A new method described about 20 years ago measures non-invasively the arterial pressure by placing a cuff on the finger. This then displays an arterial waveform that resembles an intra-arterial pressure waveform. This is my summary of the literature on the use of the so-called finger cuff method. It generates a remarkable reproduction of the arterial waveform, and in hemodynamically stable normal patients, this pressure correlates acceptably with invasive arterial pressure. But it may not be reliable in critically ill and unstable pressure. It does not allow measurement of blood gases or other blood samples. In my opinion, the risk and delay of placing arterial lines is not substantial, although it bothers non-anesthesiologists, and it may not be cost-effective. A further discussion of this technology appears in the expanded version on Canvas. The other approach is invasive monitoring of arterial pressure. The advantages of arterial pressure lines are summarized on this slide. Some of the indications for use of arterial lines are also summarized on this slide. The arterial pressure provides various components, which I will briefly describe in the next few slides. The systolic pressure is the maximum arterial pressure and reflects the myocardial effects on systolic wall tension and myocardial oxygen demands. It influences left ventricular afterload and hence LV output and ejection fraction. It reflects the vigor of left ventricular function, and influences the stress on arterial pressures, vessels such as aneurysms and suture lines. Unfortunately, it is easily distorted, providing false representation during both invasive and non-invasive monitoring. The diastolic pressure reflects coronary perfusion pressure and determines the pressure that the LV must develop before it can eject. A low diastolic pressure may suggest a low systemic vascular resistance or high runoff, such as with aortic regurgitation or AV fistulas, or it could be a sign that there has been a shift in the zeroing of the transducer or that the transducer is at the wrong level. The mean arterial pressure, in my opinion, is the most important arterial pressure because it reflects the perfusion pressure of tissue beds. It is also used to calculate cerebral perfusion pressure and systemic vascular resistance, and it is the one that is least distorted by transducer systems and the most accurate pressure determined by automatic oscillometric methods. The arterial dPdt, the rate of rise of the arterial pressure, is used to determine the destructive effect of arterial pressure on arterial walls. It is also influenced by contractility, and some use it to assess contractility, but it is also influenced by preload and afterload, and is of questionable validity when measured by hydrostatic transducer system from peripheral arteries. The arterial pulse pressure is the difference between systolic pressure minus diastolic pressure. It reflects stroke volume, but is also modulated by compliance, resistance, and contractility of the left ventricle. The area under the systolic pulse curve is proportional stroke volume and is being used to calculate and monitor cardiac output, which we will describe subsequently. The variability in pulse pressure is also being used to assess fluid responsiveness, which we will discuss subsequently. This is a nice review article which discusses the arterial waveform analysis and its applications. As I mentioned, the area under the curve can be used to estimate stroke volume and thus cardiac output. In this podcast, I will briefly review the use of arterial waveform analysis to estimate stroke volume and hence cardiac output. A more detailed discussion of this technology to measure cardiac output will be covered in the expanded version on Canvas. As I mentioned, the area under the arterial waveform obviously is directly related to stroke volume, but it's influenced by many other factors. In the past, this was solved by calibrating the area under the curve against another method of measuring cardiac output. Eventually, bioengineers developed ways of estimating the effect of resistance and compliance from a complex analysis of arterial waveform and are used to estimate stroke volume without external calibration. Several commercial systems are available, and these are calibrated against pulmonary artery thermodilution methods and fine-tuned periodically with updated versions. This is discussed in more detail by this review article that I mentioned by Dr. Thiel. Fully non-invasive pulse pressure analysis is now available with this technique of finger cuff, originally described by Nexfin and now used by the ClearSight system by Edwards Laboratory. These automated systems do a fairly good job of estimating cardiac output, but a more detailed description of this will be provided is provided in the expanded version on Canvas. The one we use in our department is the FlowTrack system. Now carries the trade name of ClearSight. It uses a complex algorithm which is described on the expanded version. It says Wiki here, but it should be on Canvas. And it's been revised several times and is now using the version 4. Although this is more accurate, it is still imperfect in a number of circumstances, including patients with on vasopressors, patients with low cardiac output, patients undergoing cardiothoracic surgery, and other exceptional patients. On this slide, I've summarized some recent studies of the most recent version of FlowTrack. And on this slide, I've summarized the results of recent studies. In general, the accuracy is not adequate for patients undergoing colectomy, patients undergoing who have low cardiac index, liver transplant patients, and patients undergoing cardiac surgery. This is a recent review in patients with circulatory shock, and again they found the percent error was totally unacceptable at about 66%. This shows the regression equation in the Bland-Altman curve showing, although on average the bias is very low, but in individual patients, tremendous inaccuracy. And even trending, all of the trends should be, of course, in the green box, but there are notable exceptions when the two devices went in opposite directions. So not acceptable in seriously ill patients. Again, I mentioned that the finger system has been used to measure cardiac output, as demonstrated on this slide. And again, I've provided some recent references on this technique. And this review article, which suggests that it is reasonably useful in healthy patients, but doesn't meet the criteria for clinical interchangeability. The same conclusions was reached by this other review paper from 2017. Now, another application of arterial waveform analysis is the use of it to assess intravascular volume. In the expanded version on Canvas, I have gone into great detail on the assessment of fluid responsiveness by various methods. I will now discuss the use of pulse pressure, and there's a typo error here. It should say pulse pressure variation, PPV, to assess volume responsiveness. As you know, arterial pressure varies with ventilation. This is more obvious during positive pressure ventilation, but normally it is less than 3 to 5 millimeters of mercury, or less than 5%. This is a slow time expanded version of arterial pressure with respiration. You see, normally it goes up and down, but only a few millimeters. The effect of positive pressure ventilation on arterial pressure can be expressed in various ways: systolic pressure variation, pulse pressure variation, stroke volume variation, a typographical error here, and plethysmography variation called pleth variability. Large variations with positive pressure variation predicts good response to intravascular volume loading, so-called fluid responsiveness. This is how pulse pressure variation is measured. You measure maximum pulse pressure, minimum pulse pressure, take the difference and divide by the average, and that gives you the percent. Maximum minus minimum divided by average times 100. The threshold or discriminatory value for detecting fluid responsiveness varies, but on average is found to be around 12 to 13%. If it's greater than 15%, the patient is likely to be fluid responsive. If it's less than 10%, they're unlikely to be fluid responsive. If it's in this gray zone, there's about a 50-50 chance of it reflecting fluid responsiveness. This is a recent study that assessed various methods of assessing fluid responsiveness, but I'm focusing in on the data they provided with the system we use here, the Phillips pulse pressure variation. And you see that the area under the curve here, which is this thick black line, is quite good here. And in fact, the area under the curve was about 92%, which is very good. But notice that the gray zone is somewhere between 14 and 18%. This shows the sensitivity and specificity of the method. And you see, of course, the sensitivity or the specificity is very good at very low values, but as the values get higher, then the specificity goes down. Conversely, the sensitivity is poor at low values and gets better with high values. So the best zone is in this range here, a balance between sensitivity and specificity. And as indicated in their data, it's quite wide and relatively high, somewhere around 14 to 17%. This would imply with pulse pressure variation, the system we use here, that when it's under 14%, probably they're not fluid responsive. If it's over 18%, they're likely to be fluid sensitive, and between this range, it's almost like a flip of a coin. These are some other studies of pulse pressure variation, and you see that in general, the sensitivity and specificity is around 0.8. This is an interesting study because nowadays we tend to use low tidal volumes. The method is inaccurate at these tidal volumes, but they found that if you briefly increase the tidal volume to 8, that this would improve the sensitivity and specificity. This shows that in the prone position, that the method is accurate as long as they aren't too obese and still have normal compliance. But when they're obese, a BMI of only over 30 or a compliance of less than 30 cc's per centimeter of water, it becomes less value. This is an interesting study that showed that in their study the threshold was 12. The area under the curve was about 0.95, the sensitivity and the specificity about pretty good. On the other hand, these two studies showed that it's not helpful in patients undergoing VATS or open thoracic surgery or cardiac surgery. Another way of assessing fluid responsiveness is stroke volume variation. Although theoretically you would think it would be the best method, it turns out not to be the best method. Because most of these methods are not as accurate as measuring stroke volume as arterial lines are at measuring pulse pressure variation. So it turns out that pulse pressure variation is a little more accurate than stroke volume variation. As indicated on this slide, stroke volume variation can be monitored in various ways. In England, they use esophageal Doppler. It can be derived from analysis of arterial waveform analysis, which we've just described, and it can be derived from echocardiography. This study looked at how accurate stroke volume variation is in predicting fluid responsiveness, and I won't devote time on summarizing this, but you can see the cutoff ranges quite widely, and the area under the curves are generally around 0.85. In the expanded version on Canvas, I've described in more detail the use of the FlowTrack system, which is what we use now called ClearSight. How useful is stroke volume variation in assessing volume status? Does it improve clinical outcome is a fundamental question, and unfortunately there's limited data that shows it improves clinical outcome. There are many limitations with the use of respiratory variation to assess volume status. It's limited to intubated patients on controlled ventilation without any spontaneous breathing. They must have a regular rhythm. You have to have a good quality arterial waveform. It's influenced by parameters of ventilation, and the tidal volume has to be greater than 8 milliliters per kilo, and they have to have normal lung function. The impact of patient position and abdominal distension and compartment syndrome is unknown. The reliability in pregnancy and children is not yet documented. And in my opinion, the difference between the positive and negative values is very small. The difference between 10% and 15%. The cutoff values are determined by post hoc analysis and vary widely between 8.5% and 15%. And so there's this wide gray zone in which, unfortunately, about a third of our patients lie within this gray zone. Finally, it has not been well studied prospectively, and the beneficial effects of its use in clinical outcomes are not yet clearly demonstrated. In the expanded version on Canvas, I have gone into great detail on other methods of evaluating fluid therapy during mechanical ventilation. Let me now turn to the important topic of complications of invasive arterial lines. The most important are false information. This can be due to the problems with the transducer system, position of the transducer relative to the patient, ringing and dampening, which I'll discuss briefly in a few minutes. You can also get false information due to vasodilation, proximal occlusive disease, and during occlusion of the subclavian artery. Other complications are summarized on this slide. The one I would like to mention here is the risk of infection. Unfortunately, there is confusion in the minds of many clinicians and even textbooks. Many consider the risk to be low, especially compared with central venous lines. However, there are numerous studies now that have demonstrated that the risk of colonization and bloodstream infection associated with arterial lines is comparable to that associated with central lines when placed in comparably ill patients for similar lengths of time. There is also strong evidence that the use of antimicrobial patches will decrease the incidence of colonization and major bloodstream infections associated with arterial lines, as well as it does with central lines. In summary, arterial lines are associated with similar rates of infection as central lines when placed in critically ill patients for similar lengths of time. On the other hand, if placed in healthy patients for only a day or so, then the incidence of infection is very low. Therefore, I believe you should use strict aseptic technique during insertion and place antimicrobial patches around the catheter exit sites. However, this is no longer recommended at our hospital, despite objections from Dr. Hatton and myself. Lines should be checked daily and removed if you suspect infection. Whether you should wear sterile gowns is a matter of debate. I think it's a good idea, but others don't agree. Now, where should you place arterial lines? This includes choosing a site, choosing a side, whether you should use Allen's test, how to set up a transducer system, and some details about radial artery cannulations. There are many sites for placing arterial lines, and on the next few slides I've summarized the sites and their pros and cons. I will let you take time to study this slide and see my summary. Anesthesiologists should consider which side you should use. If they're going to do operations near the left subclavian, such as coarctations, PDA, thoracic aorta, then you ought to be on the right side. If they're operating on the ascending aorta, I personally use it for both sides. If they're doing limas, some prefer the right side. If they're going to cross-clamp the descending aorta, you need to use the femoral. In my opinion, if you're going to place a pulmonary artery catheter and going to induce the patient, I prefer placing the arterial line before induction and before doing the pulmonary artery catheter. There's a great controversy about the Allen's test. The Allen's test is designed to detect the adequacy of collateral flow into the arm. Dr. Slogoff, a great leader in anesthesia, wrote a paper years ago suggesting it's useless because there are both false positives and false negative results, and extrapolated this from a small study that he conducted. But most authorities recommended if you have the time, you ought to do the test. On this slide, I have summarized how I recommend doing the Allen's test. You can study this on your own. I also recommended the reverse Allen's test. This is to determine if the radial artery is supplying the hand. Many of our patients have had previous radial artery lines or catheterizations done by cardiologists, and the radial artery is no longer supplying the hand. However, if there's good collateral flow, you may still feel a pulse in the radial artery distal to the puncture site, and you may be misled to think that the radial artery is supplying the hand. Therefore, I recommend that you occlude the ulnar artery and see if the radial artery is actually still perfusing the hand. I've described how to do this on this slide. In the Canvas expanded version, I've described how to set up a transducer system, which I think you should all be familiar with, and I recommend you review this section. On the next few slides, I've described my technique for placing radial artery lines, but it's just my prejudices and certainly not evidence-based. I will let you study this slide in your leisure. I've also described in detail how I recommend suturing arterial lines. I recommend always suturing, even if they're only going to be there for a short time, to minimize the risk of losing it, but not everyone agrees with me. Again, I've described this in great detail on Canvas if you are interested in reading about it. For brachials, I personally use a 20-gauge single-lumen pediatric IJ, and for femorals, I use a 16-gauge single-lumen IJ kit. Although national guidelines do not recommend routine use of ultrasound for arterial lines, many of you use it, and I can't discourage using it routinely. A side effect is people have lost the skill of doing art lines without ultrasound access, but as long as you always have ultrasound access, maybe that's the way to go. In this systematic review, they found that clearly there is improvement in success rate using ultrasound. So I think it's useful in femoral, brachial, and axillaries. It's useful in finding the radial artery when you're going proximal to the wrist, and perhaps we should be using it routinely. Although I think as a skill you ought to learn, I think you should learn how to do it without ultrasound, but maybe that's a thing of the past. A few words about electronic pressure monitoring, which we use on all arterial lines. There are many problems associated with electronic pressure monitoring. Improper zero gain, improper positioning of the transducer, and distortion due to ringing and dampening. And finally, unequal pressure in the arms or lower extremities. Ringing describes exaggerated response to phasic variation in pressure seen in arterial and PA lines. It results in a noisy trace with extra spikes, and the significance is it causes a false elevation of systolic pressure and a depression of the diastolic pressure. But fortunately, it does not affect the mean pressure, which is again one of the reasons I favor monitoring mean arterial pressure. This is an illustration of ringing, and note these extra spikes on the trace, and it causes a false elevation of systolic pressure and a false depression of diastolic pressure, but the mean pressure isn't affected. Ringing is due to resonance in the transducer system, and it occurs when the frequency domain of the biologic signal coming out of the arterial wave overlaps with the natural frequency of the transducer system, and the system is underdamped. As I emphasize, this causes false elevation of systolic pressure and false depression of the arterial pressure. I strongly recommend that you review the details that I've provided in the expanded version of Canvas, on Canvas. Dampening is the opposite. If this is a picture of the input signal, ideally the output signal would be perfect. In an underdamped signal, this is the input signal, but you get this ringing and false elevation of the systolic pressure and false depression of the diastolic pressure. When it's overdamped, you get the opposite, a false depression of the systolic and a false elevation of the diastolic pressure. There are various ways of expressing dampening, but it's typically depressed as the damping coefficient. If it's 1, it's unresponsive. If it's less than 0.3, there's prolonged resonance. You can never achieve perfect, but the optimal is somewhere between about 0.6 and 0.7. Again, this is more thoroughly discussed in the expanded version, and this should say Canvas. And that completes this podcast. However, I have added the study questions, and I will give you time to look at each of these